Okay, sorry about that. Again, thank you, Leanne, for reaching out and for all of you for being here today. You serve a critical, important role in our community and in our society. It's really my pleasure and honor to be able to speak to you today. I am an executive director of a national nonprofit organization. As you heard, I spent most of my time working in suicide prevention, developing programs that are used around the country and around the world. I'm a consultant to the World Health Organization and the International Association developing programs. And one of the areas that is really important to me on a personal level is the legal system. My father was an attorney for 50 plus years. He worked in the divorce and custody area, and I had the pleasure and honor to work with my dad for about 25 years of my life growing up. And just as a kind of a fun side note, for those of you who might remember the television show LA Law, and I'm sure some of you might remember that, the divorce lawyer on that show that character was based in part off of my dad. So I had a lot of experience dealing with a field that has lots and lots of stress, and I'm excited to be able to share some of this information with you today. So we're going to jump right in. Here's kind of what we're going to cover, some basic foundational concepts so you understand a little bit about suicide prevention and what we know and some of the data on this and around mental health. That's where we're going to start and build. We're going to go from mental health to suicide because we know that as people go from being well to being ill to a risk of suicide, it's on a continuum. So we'll start with wellness and mental illness issues. Talk a little bit about risk and protective factors, how to identify what some of those things are, and really the warning signs. All are important to know for different reasons. We'll cover some of that. Then I'm going to go into a bigger section on how to help somebody. What is it you need to do? What are you asking? What are you listening for? We're going to end on what do you do after? How do you help somebody after they might have attempted or thought about suicide, been hospitalized for an ideation period, or if somebody died by suicide. So we have a tremendous amount that we're going to cover today in this brief amount of time. So we're going to start with the foundational concepts here. Just a couple things for judges. We know that the canon for judges says that a judge shall perform their duties impartially, competently, and diligently. Competently is where the mental illness component comes into this. When we know that judges and attorneys struggle, just like everybody else, they're all human, that can affect their ability to perform their work. And this is not just in the courtroom. This is also, as you can see under Canon 3, around administrative responsibilities. And so that's interacting with clerks, with administrators, with anybody that's behind the scenes. We need to have judges that are doing well. For the American Bar Association, the rules relating to the representation of clients is similar, provide competent representation. Competent representation requires knowledge, skill, thoroughness to be able to provide that representation. It means that you have to be in the right mind to be able to provide the services to your clients that they're expecting. And when you're impaired due to a mental illness and it's impairing your ability to function, that's where we see attorneys really struggling. Just a quick note about the Bar Association rules related to disclosure. People do ask about this a lot. Can an attorney disclose if their client might be thinking about suicide? And yes, the rules do provide for that. As you can see here at 1.6, to prevent reasonably certain death or substantial bodily harm. So if we have a client that discloses they might be at risk of suicide, whereas we normally would keep everything very confidential, the rules do provide that can be disclosed outside of this. So that's part of the foundation, right? That's really for the profession itself. That obviously doesn't cover some of the other administrators, the court deputies, the legal assistants, any of the researchers, the clerks, any of the administration. But for that part, we do need to cover some of those things. I also wanted to briefly mention that the National Strategy for Suicide Prevention, we released this in 2012. I was one of the co-lead authors on this. And as you can see in here, goal number 7 in the strategy actually includes your roles. You can see that the professionals include divorce, family law, criminal defense and other attorneys, as well as others involved in the criminal and civil justice system. That's everybody. That's everybody that's on this call, whether they're inside a courtroom or behind the scenes, filing in the courthouse. Any roles that you have really are covered under the National Strategy for Suicide Prevention as a key role in being able to be involved in suicide. So with that, let's get started with the mental health component of this. Mental health is still stigmatized, not quite as much anymore as it used to be, and definitely not as much as suicide is, but mental health still has a stigma attached to it. There's no doubt about it. And why this is really important is because when somebody feels stigma, shame around the topic of mental health, it reduces the likelihood that they will seek help. It impairs their help-seeking ability. So we want to try to break down stigma around mental health and around suicide whenever we can and make it okay for people to talk about that. When it comes to mental health, we know that mental health impacts, it starts in our brain, and it affects really our whole body. It affects how we think, it affects our ability to attend and pay attention, concentrate, focus, things like that. But it also affects your body. It can literally slow down your entire body so that you become non-functional. You might sleep all the time. You might not have any appetite at all. It can cause aches and pains. As a matter of fact, if we look at a scan of somebody who's struggling with depression, a brain scan, what you can see in the brain is that the brain isn't working as much. Literally, there's not as much activity happening throughout the brain and the spinal cord. And as that happens throughout the rest of the body, we see deterioration. It affects about 50 million Americans, and that's only the known number of Americans. We don't know how many others really could be diagnosed but don't have insurance or don't have access to care or just simply don't get care. But we know it affects many, many millions of Americans every year. There's a number of factors that contribute to mental health issues. There's biological factors, there's genetic factors, brain chemistry, the electrical circuitry in the brain. Sometimes it's a traumatic brain injury, so it's really structural issues in the brain. All of these things can start a mental health challenge for people. Life experiences, any kind of exposure to trauma can impact mental health. So you might have somebody that's just struggling, and then you add on an exposure to a traumatic situation at home, and this might be early on, it might be one time, it might be multiple times, it might be something in your environment that you see that's traumatic. That can contribute to mental health issues. And a family history, we do know that mental health does seem to pass on from generation to generation. How that gets played out for everybody is very different, however. So you might have a genetic predisposition, for example, for schizophrenia, a thought disorder, but it never play out for you if you don't have other stresses that trigger that gene. We know some people where depression runs in the families. There's some that really struggle with it, and there's some in families that struggle with it occasionally, and some that don't really struggle with it at all. We still know it runs in families. So we know that there's many contributing factors to mental illness. Just as a brief thing on data around mental illness, 1 in 5 adults will experience mental illness in their lifetime. 1 in 5. So you can think of all the people that are on this call and look at how many 1 out of 5 is. That's a lot of the people on this call that will experience that. 1 in 25, about 10 million Americans, will have a serious and persistent mental illness. These are illnesses that are chronic. They might be schizophrenia. They might be a major depression that doesn't go away or continues to come back recurrently over time. About half of the illnesses really start very early on in life. They start really sometimes in childhood, and then they really start to flourish in adolescence when the brain starts changing. It really changes structure, and the chemicals throughout the body start changing. But most of it starts pretty early on in life. And we have millions of Americans that live with co-occurring illnesses, so mental illnesses and substance abuse issues. So this is pretty widespread in terms of the impact. If we break this down and we look at mental illness just in North Dakota, you can see about 20% of those adults in North Dakota are diagnosed with mental illness. 20%, again, 1 in 5. About 5% diagnosed with a serious and persistent mental illness. So those numbers pretty much match the country in terms of what we see, but it's not just something that happens in another state or in another county. It is really everywhere. Let's shift to data on suicide for a moment. Roughly about 800,000, somewhere between 740, 800,000 people around the world die by suicide every year. That's 1 death every 40 seconds. Every 40 seconds with a rate of about 10 per 100,000 people. In 2020, about 46,000 Americans lost their life to suicide, which is about every 11 minutes, 125 people every day, and a rate of 14 per 100,000. So you can see if we look, our rate of death is a little bit higher than it is around the rest of the world. We see lots and lots of people that are dying by suicide. We saw up until the pandemic started in 2020 and 2021, we saw every year a rise in suicides. It wasn't a steep incline, but we saw steady growth in the number of suicides, getting up to about 48,000 or just over 48,000 in 2018. We saw a drop in those 2 years of the pandemic, and we have already seen an increase back to this level. Actually, we're above this level now of 2020, going into the 2021 data, and very concerning about 2022. Who's dying by suicide? Well, more males die by suicide than do females. True around the world. There are a couple countries where females die more often, but by and large, males die by suicide more often, 3 to 4 times as often. And you can see there, out of the 46,000, the majority of those were males. If we look at age groups, the way that the government breaks down age groups of looking at suicide, what you can see here is that the older population is about 20% of all the suicides. Middle age is about a third of all the suicides, whereas youth is only about 13% of all the suicides. Why this is important is that most people think that suicide is primarily a youth issue. It isn't really primarily a youth issue. You can see here the numbers. It's only 13% of all the suicides. The majority of suicides are those in the middle age, the working age, and our senior citizens. Our senior citizens have the highest rate of suicide. So if we look at how many people there are per 100,000, that age group, the senior age group, 65 and older, has the highest rates of suicide. This occurs across the lifespan. It also occurs across all demographics. Caucasian Americans, primarily in the United States, but we see it also in African Americans, Hispanic Americans, Asian Americans, Native Americans. And although the numbers, so if you look at the 700 some number for Native Americans, that number of actual deaths is very low compared to the 46,000 we lost. Their rate of suicide is double that of Caucasians because there's not as many Native Americans. What this tells us is that suicide cuts across all genders, all races, all geographic locations. But what we don't know really is around the LGBTQ status, that population of individuals. It's not coded on death certificates, so we don't know how many are actually dying by suicide that are LGBTQ. We do know that they tend to think about suicide more and they attempt suicide more, but we don't actually have data on that in terms of demographics. How are people dying? In this country, it's primarily by firearm. It's just over half by firearm, and that number has remained really very stable over the last 10 to 20 years. 50, 51, 52%, 50, it's always in that range. Suffocation and hanging would be the second way. This happens frequently in jails or those incarcerated, and actually in hospital settings. Poisoning is a little bit lower, but then you see all the other smaller numbers. These are jumps or falls, people that might drive into another car, drive into a barricade. But by and large in this country, it is firearms. Why is this important is when we talk about prevention, we're looking at reducing access to lethal means. Anytime we can reduce access to something that the person who's at risk of suicide thinks is going to work, and that's most readily accessible to them, that's what they're going to choose. And we know, especially in rural communities, access to firearms is greater. So we see higher rates of death by firearm in this country. Around the world, the leading method that's used for people to die by suicide is ingestion of pesticides. Again, rural areas, that's the most used. A quick note on attempts. We have about 1.2 million attempts in the United States every year, one every 27 seconds. So we have a death every 11 minutes. We have an attempt every 28 seconds. And probably the most key thing on this particular slide is, whereas I was talking about more males die by suicide, more females attempt suicide. So we can't just pay attention to males because they die more frequently. And in fact, we've been seeing over the last 5 to 8, 9 years an increase in the lethality, the way in which females are attempting to take their life, and they're actually dying at greater numbers than they did before. So we have to pay attention to those attempts, because we know a prior attempt is the greatest predictor of somebody who might die by suicide. So again, knowledge base here. If we have somebody that we're working with that we know that attempted suicide, we know they're at greater risk of dying by suicide. In particular, the first couple of weeks, 2 months after an attempt or a hospitalization, if we can get them stabilized out about a year after an attempt, it comes back down to baseline. But these first couple of months is when we really see a lot of people struggling in reattempts. A note about where we're seeing people die in this country and around the world. You can see in this country, those states in red are where we see most of the deaths in this country. Now, you can actually break the United States down to counties, and you can see a very similar pattern. Where it is more rural, we have more deaths. So you can look at, for example, the 3 states that have the most number of deaths are California, Texas, and Florida. They have the most actual numbers of people dying, but they also have huge populations. So their rate of suicide is very low. Whereas in Mountain Midwest states, including North Dakota, you can see the rate, the 22.3 rate versus 14 for the entire country. So we see people across this country, across counties, dying by suicide. And on the right side, you see around the world, those where it's darker, we see more deaths by suicide. There are many countries that still don't report data, underreport data, but you can see where we fit around the world. A little bit closer to home for you. Last slide on data is about North Dakota. It's the 11th leading cause of death overall, 11th leading cause of death. Second for 10 to 44-year-olds, second leading cause of death. The only other leading cause of death is accidental injuries. That's it. Unintentional injuries and accidents is the number 1. But for a huge age range, 10 to 44, it's suicide. 7th leading cause of death for 45 to 54, and the 10th leading cause of death for 55 to 64-year-olds. We have over 3 times as many people dying by suicide in 2019 than in alcohol-related motor vehicle accidents, and the total deaths equal to over 3,000 years of potential life lost before the age of 65. So we have a massive problem here on our hands, a massive public health issue that's cutting across everybody, and this is why we need to know a little bit about what are the risk and protective factors and the warning signs before we jump into how do we help somebody and what do we do in these instances. I started out by talking briefly about my dad and his field. You work in a very, very stressful field. It doesn't matter what role you have in this industry. There is a lot of stress, and it is constant, and it is always changing, and it seems to be getting worse, which is why I actually like that picture in the middle, is that stress is not only higher for you, but the stress level seems to be getting higher as more and more conflicts happen in our society and in our world. More violence happens, more family disputes, more domestic violence, more drug court things. All of these things are increasing the stress in the profession. There are a number of somewhat generic risk factors that might put somebody at greater risk of dying by suicide. Now you can go online and you can literally find thousands of risk factors that might tell you somebody's at greater risk. So as I mentioned earlier on, if you have a family history of mental health issues, or definitely a family history of suicide, you have a greater risk of that happening in your life. Your environment, if there's trauma, if it's chaotic, if it's fragmented, if it's moving constantly, if there's a lot of chaos, if there's financial distress, that can cause you to be at greater risk of not only having a mental health issue, but that mental health issue kind of building and fostering towards the suicide risk. Any kind of physical or chronic illnesses can create additional risk for people. Access to care. If you don't have access to mental health care, physical health care, your regular doctor, primary care doctor, that can increase risk. We know that, as you saw as you get older, your risk actually goes up in life from youth. So we know age, gender, sexual orientation, all of those things increase risk. We know substance abuse and suicide are connected. I have a slide on that I'll show you in just a little bit. All of these things increase your risk. Here's before we go a little bit further, let me just say one thing about risk factors. They're really important to know because they help us identify who might be in trouble or some of the things that we should watch for in somebody as risk goes up. We look at the meta-analyses, these big studies that have been done looking at many other studies, so multiple groups of people, thousands and thousands of people. What we find is if we just think that risk factors are going to tell us who's going to die by suicide, it's a flip of a coin. They don't really tell us that. They tell us who might be more in trouble. And that's why it's important to know them. Because we know that people that are dying by suicide are not doing very well as they slip down that continuum. This is why we want to know about risk factors. On the other side of the coin are protective factors. Now, we don't have nearly as many protective factors identified in the literature. Protective factors are those things that are they're buffers, they're barriers, they're things that help lower your level of risk. Being connected, the more connected people are to family, friends, faith community, anything in hobbies, anything that they could be connected to, that lowers their risk. It doesn't mean that somebody might be very well connected to all of those things and still die by suicide. But we know that the more connections we have, the better. When we see less of them, we see greater risk. So we want to build on protective factors. We want to build on life skills, problem solving, communication skills, coping and adapting, resiliency kinds of things. How do you bounce back when you're faced with adversity? How do you deal with anger? And how do you deal with communication, not just in the public, but at work and at home? All of these general life skills, the more we have of them, the lower our risk. And the more access to care we have, the more access to all different kinds of care we have, that helps us. It protects us from other things from happening. Now, there's some specific things within your profession, in your careers, that are also risk factors that I wanted to mention. The importance and the impact of the decisions that are being made. And that can affect everybody from the judges to the lawyers to the clients to the deputies to the clerks and all of the people that have the information that might have to hold the information and what you might know. Those decisions are big decisions. They have big impacts on lots of people's lives, and that's very heavy for people. Caseloads are very high, and the demand is up in terms of the need for services for our judicial system. Attorneys themselves really struggle. Attorneys have higher rates of suicide than other professions do. Caseloads are high, billable hours are high, stress and demands are high. Changing laws make things very difficult. You have some defendants, some litigants that want to be self-represented. That adds a whole other layer of stress in the judicial system that other industries don't have. It's not as if somebody needs surgery, their appendix removed, they can go do that on their own. But people in the legal system, they can represent themselves, and yet that can really add to the stress that you all experience. General work conflict. There isn't a workplace that is perfect where everybody gets along all the time, so that can add stress to things. The expectations of the judicial system being completely unbiased, and the way media portrays the judicial system, how it's portrayed in entertainment industry, that changes people's perceptions about the work that you do. These things, all of these things that you see on this slide really, really contribute to risk for those that are on this call. I think one other thing is the sense of perfectionism, competitiveness, the independence, the sense of responsibility that you all feel in the work that you do increases your level of risk because it is very, very important work to be done. So we have risk and protective factors. We also need to talk about the warning signs. What are the warning signs? So the way we tried to figure out what the warning signs of suicide were is we looked at people who had died by suicide and what was happening for them over the last year. And we came out with this list of warning signs. And there's two in particular that are in red that I want you to pay attention to, but some of the other ones are just as important. The good news about that is that we have a list. These aren't perfect, however, because again, as you heard me just say, this was normed on people over a year. So people might have been 6, 8, 10 months out from when their attempt occurred and exhibited one of these things, and it wasn't caught. Nobody saw it as a warning sign. We don't have good data on the week or 2 weeks before a death to tell us anything different relative to these warning signs. So this is the best that we have in our field. So what are the research-based warning signs? Well, communicating about suicide. We know that unfortunately, the majority of people, about 80 to 85% of people, communicate their intent around death and dying before their death. And I should say, and I should have said this up front, for those of you that are survivors that have lost someone to suicide, I share that sympathy with you. I lost 6 patients of mine to suicide. I lost friends to suicide. I lost a family member to suicide. It's very hard. And some of these things are hard to hear, especially when we hear that they communicate about this. The trouble is that they don't communicate very directly. They don't come out and say to us, I'm going to do this at this date, at this location, in this way. They just don't do it that way. They say things like, everybody would be better off without me, or my division would do much better if I wasn't here. The team that I'm on would like it much better if I wasn't around. And we don't see that as a warning sign. We don't pull it all together with some of those risk factors and some of these other warning signs. So we know that people communicate their intent to die or their thoughts about death and dying. It's just not often very direct. And then the second thing that they do is they look for a way to die. They look for a method. How can they do this? What is most accessible to them? Is it a gun? Is it someplace they could jump from? Is it a rope? What is it that they're going to be able to use that they really believe is going to work to get them out of the pain that they're in? Those two things, wanting to die and looking for a way to die, are the two things that 100% of the people did. 100% of the people that died by suicide did those two things. Now, somewhere in the 60 to 70% range of people also did some other things. They talked about feeling hopeless, that they had no reason to live any longer. There was no purpose for them any longer. They didn't have anything to give back to the world. They talked about feeling trapped, that there was no way out of the situation that they were in. And many talk about unbearable pain. And I really want to emphasize that word, because as something that you might be looking for or listening for is unbearable. Many, many people, when they are communicating their intent, use that word. It's unbearable. They're trying to, as best they can with their brain, to convey to us that they literally can't take it any longer. It's very, very infrequent that we hear people talking about pain in that degree, that it's unbearable. Now, you might all know that if you have the fortunate experience to go to a hospital, they have pain rating charts that are in emergency rooms, right? They have smiley faces, they have colors, they have numbers, all of that. And if you're above an 8, you're in the red, and you're in a lot of pain. This is the level of pain that we're talking about for people struggling with a mental health issue and thoughts of suicide. It is unbearable. They can't take it any longer. So we hear them talking about these things. Those are the things that we really want to pay attention to. Now, some of the other things that they do, they might be very reckless. They might drive a little more erratic. They might not do their jobs the way that they're supposed to. They might just be a little more haphazard in everything that they're engaged with. They might change their sleep patterns. They might withdraw. They might pull away from family and friends, work activities. All of those things do happen. And we know that some of them really display a lot of these symptoms that are more consistent with depression, the sleep problems or the withdrawal or the not eating. They might have anger and rage or be very irritable. All of those things are less than half of the time for everybody. So 100% of the time, the two things in red. About 60 to 70% of the time, you have some of those other things where they're hopeless, trapped, unbearable pain. And then you have some of these other things that are really all over the board in terms of what people do. So I know I spent a lot of time on this particular slide about warning signs. These are the things that we're really looking for. Now, when we're talking in the judicial system, there are some things to actually pay attention to when it comes to warning signs. There have been some studies that have been done on people that work within the judicial system that look at warning signs. Anxiety, irritability, depression, and being overwhelmed. Very standard, very common kinds of things that you just heard, might be more in the judicial system. Drinking more than usual. So alcohol use, I'm going to show that in the next slide. Financial disarray, they let their finances go. And if you hear about that, if you hear about financial distress at home, that can be a warning sign for somebody working in the judicial system that we don't hear in other systems quite as much. Lack of interest any longer, lack of involvement, lack of really passion for what they do. People that work in your profession get into it for a desire to help and be involved and be a part of the community and to better people's lives and to serve. So when we see that lack of interest any longer, that's a warning sign we really want to pay attention to. Any conversations or mentions about withdrawal from family, friends, activities in their life, they just don't get engaged any longer. That's a warning sign. Obviously, the exhaustion that we hear about, there's no sleep. There's just not enough time in the day to get everything done. That's a warning sign to pay attention to. As a matter of fact, this isn't well, we have a little bit of research on this, not as much as the other warning signs, but we do have newer research on sleep that I think is worth mentioning because it does impact in your profession. We know that the majority of people who die by suicide don't sleep in the day or two before they die by suicide. As they go from being well to being ill to being at risk of suicide, anxiety goes up. Anxiety and agitation really goes up for them at the very end. And as that happens, the brain doesn't seem to think it needs sleep. It thinks it's going to have a permanent sleep coming. So that we see that they don't sleep a lot. So if you know, or you're putting all these pieces of the puzzle together, risk factors, no protective factors, a warning sign here or two, and then all of a sudden you hear somebody that's not able to sleep, that's somebody we really want to pay attention to. We really want to watch for because we think that they're at greater risk of dying by suicide. So some of the studies really in particular that have shown this are around our military and our law enforcement that show this sleep issue, but that is a pretty important one to pay attention to. And again, any of that anger, that real irritability, that out of character that you know them to be. You know the people you work with. You see them day in and day out. If they're just not themselves, it's time to start thinking about asking a question. I said I wanted to mention something about alcohol and suicide. We know there's a connection. Studies around the world vary. In this country, it's about a third of all the people that died by suicide have alcohol in their system. So that a couple of slides ago when I said, a change in alcohol use, if they start using alcohol and they never did before, or all of a sudden they're changing what they're drinking, or they're changing the amount of how much they're drinking. Anything related to alcohol, and then you add it to something around their mental health issues, we know that increases their risk of death and dying. People who suffer from alcoholism are about 120 times more likely to take their own life than those who are not dependent on alcohol. And we know, again, this is a really significant problem for those in the legal profession. There are some triggering events, and I started looking at the research out there on this, and then I started thinking about things and lawyers that I talk with and people that work in the legal field, and I was like, the list could go on endlessly here. But some of the things that the research really show us for triggering events for suicide, demands and paperwork, and this goes across the board. Again, whether you're talking about attorneys, you're talking about judges, you're talking about clerks, and the amount of work, the paperwork that has to be done, the way in which it has to be done, the rules that have to be followed for everything, the demands, very, very high for people in the legal profession. Any kind of threats from clients, defendants, inmates, people in the courtroom, and we're seeing that more and more. And people that are in the courtroom that have a mental illness and them losing control. As mental, we see more and more people with mental illnesses going to jails and being incarcerated. This increases your level of risk as well, because what it does is it puts your system, your internal system, your endocrine system on hyperdrive all of the time, and it doesn't give you a chance to come down when you've got this all day long every day. Obviously, for lawyers, the bar exam, losing a case can be very, very triggering for people. Decisions that are coming out that might impact you and where you think there's going to be an appeal, what that might look like if you're up for election as a judge. Any of these things are things that really, really can be triggering. And also retirement. We actually know that for those that are retiring, I had mentioned way earlier that the rate of suicide is higher for our seniors. But those that are looking at retirement, then this is really true in the law enforcement, the deputies, the sheriffs, their industry, but really in the judicial system as well. We see for judges, for example, that as they near retirement or they just start retirement, their risk of death by suicide goes up. So really, it's during careers, all of the careers that you're doing, and after, that we have to pay attention to people. How do you do this? What is it that we're trying to do? We want to help somebody at risk. First is you got to ask. How do you ask the question? What are you supposed to ask? Well, there's two components to this. I'm going to start with just very generic, and then I'm going to move into how do you ask if it's about suicide. If you don't know if somebody's at risk of suicide, you don't have any reason to believe that, nobody's told you anything, you just don't know, but you're worried about them. Something doesn't seem right, something seems off. You want to start a conversation. Now, here's the key about starting this conversation. As you can see in these examples, there's two parts to it. You haven't seemed like yourself lately. Something is going on. And then there's a second part to the question. Is there anything going on that I can do something about? Let's talk about it. I want to help. Are you okay? What we're trying to do in these starter conversations is open up a dialogue. And you're giving feedback. You're saying, I'm observing something. Something is off. And you're saying, I want to be there. I want to help. What can I do? That's how you start just a generic conversation if you think something's going on, you don't know about suicide yet or not. Now, if you do know that there's a risk of suicide, either somebody's voiced something, you saw a warning sign, maybe somebody indicated that to you, you walked by a computer and you saw somebody researching something that looked like suicide-related content, you need to ask the question. Now, there's a key to this as well. You need to ask the question very directly, and you need to use a fatality component to the question. When I train doctors, I teach them how to do this because most of the time people don't. They'll say things like, hey, you don't seem like yourself. What's going on? Are you really having a hard time lately? Let's go get a cup of coffee. When somebody's at risk of suicide, their brain is at the place where they can only think about pain, the unbearable pain that they're in, and that death is their only way out of it. That's all their brain is thinking about. So that means the question we have to pose to them has to be at that place. We have to connect our brain to their brain, and their brain is on unbearable pain and death. So think about this if you're going to ask the question. And it doesn't matter what words you say as long as there's that fatality component to it. Are you going to kill yourself? You've been thinking about killing yourself. You think you want to die. You just don't want to live anymore. You don't want to be around any longer. Whatever word it is that you can use, what I tell people is pick one. Pick one phrase, practice it. For me, doing this all the time, I'm used to this, so it's easier for me to say this, but most people don't say this very often, if at all. So it's very hard when you're faced with the situation you have to. So practice it. Think about what it is you want to say, but do remember, if you are in a situation where you might know, or even if you start that conversation and they do allude to suicide, you need to ask the question and you need to ask it directly. Then you need to listen. We need to pay attention to certain things. We're listening to see if they have any reasons to live. If they don't have any reason to live anymore, everything is gone for them. There's no hope for the future. There's no hope that treatment can work, medicine, therapy. If they've tried therapy and it didn't work, it's never going to work. If they have no reason to live anymore, that puts their risk at a bit higher level. So we want to listen. Are they looking forward to a graduation for their child? Are they looking forward to getting married? Are they looking forward to retirement? Do they have specific reasons to live and against death? These are the things we want to listen for. Those things can actually help us engage them in a conversation. Do they have any sense of ambivalence? We know that as people get closer and closer to death by suicide, there's this sense of ambivalence that happens for their brain. Their brain seems to play tricks on them, actually. If this happens, I won't do it. If this does happen, I will do it. We want to listen for them questioning about what's going on in their world right now. Again, more opportunity for engaging with them, but we want to listen for those things. Connections, as I mentioned, they're really important. Do they talk about them? Can you build them? Can you help them with them? Can you give advice on them? Can you suggest ideas for different connections that they can have? What support systems exist for them or not? Anything about the future that they talk about, if they have something they're looking forward to in the future, we can really use that as an opportunity. But that means that's what we're listening for. Now, we do want to also avoid some things. We don't want to minimize their pain or discount it or be judgmental about it. This isn't the time to say, I was in your place one time too. I know exactly how you feel. We don't know that. Their pain is their pain. So we want to avoid those kinds of things. And we definitely want to avoid making promises. We can't promise somebody that we're going to get them through this and it's never going to come back before, because sometimes it does. And when we do respond, so we've asked the question, we've listened for some things, we need to respond. And what is it we want to respond with? Well, you're right there with them, right? So you're not alone. I'm here. I want to help. I want to get you to help. I want to support you through this. You may not be the person, and in fact, this training isn't designed to make you a mental health expert or a suicide prevention expert. That isn't it. This is to provide some very broad ideas on things that you can pay attention to and knowledge that you can know, and hopefully change some of your attitudes around this, which is what we think of in this field, knowledge, attitudes, and behaviors, so that you can do something different if you're in a situation like this at work and honestly at home. So phrases that help people, again, are those support messages and that they're not alone, because often people that are at risk of suicide feel very disconnected. Stay with them, at least until you make sure that they get to the care that they need. Make sure that they know there's a resource out there. Anytime you can say to somebody who's at risk of suicide, hey, there's a phone number you can call, 988, dial it anywhere, and somebody's going to answer that call. You can text 741-741, and somebody's going to do a texting conversation with you. Those things make a difference. As somebody that struggles with mental health issues and gets close to suicide, they don't see options, they don't see alternatives any longer. So when you provide them to them, that gives them a sense of hope. So you don't have to know a lot, just know that there's a resource out there. There's a phone number, there's a texting line, there's a website, something that you can give them. And definitely acknowledge their pain. Acknowledge that you hear it. You may not understand it, you may not be able to deal with it very well, the way that they're dealing with it, or the way that somebody else in your family or you might have dealt with it in the past. But that's not, you don't have to. You just have to acknowledge that it sounds really bad. It sounds like it really hurts, and you get that, and you want to get them to help. And follow up with them. We have a lot of research that tells us following up is really, really important. So after somebody has thought about suicide or attempted suicide, now whether they were admitted to an emergency department and then discharged, or admitted to a hospital and discharged, we know that immediately after that, their risk is very high. And I mentioned that 2-week span and then up to the 2-month span. So what do? We want to make sure we follow up with people. Now, let's just say you talk to somebody, you have that opening kind of conversation, they're not at risk of suicide. You still want to follow up with them. If you talk to somebody, they were at risk of suicide, but it wasn't imminent. Maybe they thought about it a couple of months ago. They're a little bit better now. They're not out of the woods, but they don't seem to need to go to a hospital. They don't have any kind of current plan or anything like that. You still want to follow up. We want to make sure that we connect with them. So however you check in with them is really important. You want to email them, you want to chat with them, you want to have a cup of coffee with them, you want to give them a call. Any way to stay connected to them is really important. Now, you want to do that in a couple ways. One is you want to do it on a regular basis. Once a day, once every couple of days, you want to check in with them at the same time. Set a plan for that person. Say, every day at 1:30 on my break, I'm going to give you a quick call. I just want to check in with you. That gives them something to look forward to as they kind of get back into the swing of things. But then also do some things intermittently so that they're not prepared for it. You want to make sure that they know that you care outside of just the times that you're regularly contacting them. And however it works, it doesn't have to be long, it doesn't have to be in depth. You just want to be able to say that you're staying connected to them. These connections make a big difference. Now we're getting to the very end here, and we definitely want to leave some time for questions, but I wanted to talk about what do you do after there's an attempt, and what do you do after there's a loss by suicide? These are very different concepts. After somebody attempts suicide and they're getting reintegrated, not only to life outside of a hospital, which can be very hard, but to their family, to their friends and their community, and then back to work. It's really, really difficult. Stigma and shame they feel is very, very high. Oftentimes, people will not even want to go back to their work because they're so embarrassed by what happened. They feel like everybody's going to walk around on eggshells around them, and we want to try to help them reintegrate as best as possible. So we want to support them through this process because we want them to get back to their normal life. Now, I would say that we need to give them a little bit of time. We need to be patient with them. They need to ramp up again on their work and how much work they can do. So we want to have some flexibility and adaptability in what their work is and make sure we make some accommodations for that. But we want to have a plan. The more you can get a conversation with this person and plan with them, how are we going to reintegrate? Well, for a couple weeks, 2-3 weeks, let's have you do this work and not this work. And then we'll start this work for a couple weeks after that. Set up a plan, engage them in the plan, let them be part of that plan, but have a plan going forward. And make sure that these things are acknowledged out publicly. We want to make sure that people don't feel like they have to walk around on eggshells, that everything that they're doing is being watched by everybody else, and that they're afraid to say anything because everybody's going to think, oh my gosh, I'm going to attempt again or I'm going to die. We want to make sure that we acknowledge this to the degree that we need to, or that the person has said that we can, or that's known by the people in our units, in our divisions, in our courts, and get back to life. Emotions vary, but trust is a very big issue. Their emotions might swing a lot in the first few weeks. So we need to be ready for that. They might be really irritable. They might be sad again. They might feel really good one day and then really struggle the next day. It swings. The brain takes a little while till it gets back in balance. We want to offer our time and our support and our patience and our understanding, but also that we have to be compliant. We have to have them be compliant with what the doctors are telling them to do in their treatment. We also want to be compliant with what our needs are. We need to get back to make sure that the rules and the procedures and the policies are being followed the best that we need to. So get back to that routine. There might be some time involved, but we do want to get them back into a regular routine. And recognize that everybody's process is a little different. Some people will be able to return much more quickly and you're coming up with a plan for them. Some people might take a little bit longer. There might be some fits and starts, but everybody's plan is a little bit different. So we want to get them back on track. That's basically what we want to do. When it comes to after a suicide has occurred, again, lots of stigma and shame for families. And for individuals. So if they lost somebody in their family, they're worried about coming back to work. What are people going to think about that? We have to adjust for that. We want to give people permission to grieve, and suicide grief is very hard. It is very difficult because of the stigma around this, the unending why question that people have, the sense of guilt about what they did or didn't do, what they missed in their life. Sometimes we just need to listen. We need to let them just talk about this, and that and help them acknowledge that we don't have answers to everything. Sometimes we might not know why. Even when people leave notes, which is only about 20 or 25% of the time, they don't really help us understand why our loved one is gone. So we need to give them permission to grieve in their own way. Do a lot of listening. We need to help them understand that the why question may never be able to be answered. We don't want to judge them. We don't want to be critical of them. We don't want to blame anybody. There's a lot of blame that goes around when somebody dies by suicide. If it's a spouse, somebody might blame the other spouse. If it's a kid, they might blame the one spouse. They might blame a therapist. They might blame a doctor, medicine, a pharmaceutical company. There's lots of blame that goes around. We don't want to do that. We want to be more on the supportive side of things. Anything we can know about suicide helps. Any basic information we can know, and any resources that we can point them to, because they feel very isolated. They don't know where to turn to. Anything we can do to help them, point them to a website, a number that they can call, a survivor support group that they can talk to, that helps them a lot. including where they are in the community. If there's any therapists that provide grief support, that's really helpful. So helping loss survivors is hard and it takes time. We got to be patient. In terms of the amount of time, what I would tell you is about 2 weeks that we want at the workplace. We want to give them about 2 weeks, and then we want to kind of start getting things back into normal. So if there's a loss in the workplace, everybody's going to grieve differently, and then we're going to kind of go back to what would be normal. And finally, there are resources for help for people in the field. Lawyer assistance programs provide confidential services. There's the Lawyers Depression Project. There's a helpline for judges. There are many, many different types of resources that are available that are available to all of you. There's also EAP systems within the courts. So we want to make sure that people know what those resources are. And with that, I have talked quite a bit. I am going to stop sharing, and I'm going to turn this back over to Leanne.
Great. Thank you so much. I do want to give you an opportunity, those of you on the Zoom today, to ask any questions. I know for me, the data was extremely interesting. We kind of talked a little bit before of just the numbers and the amounts, but to see the numbers on the screen really surprised me of how prevalent it was in our state. So we'll open it up. You can unmute yourselves and ask a question or put it in the chat if you have a question for our faculty.
Hi, Dr. Reidenberg. I'm Scott Johnson. I too was very curious about the statistics you had specifically for North Dakota. And you had mentioned the category of 10 to 44 and suicide being the second highest rate for mortality. Any thought on why that might be in rural areas, be such, looking at region, I think it was 7 or 8 that we're in, why that might be? And second question would be, so what could or should we do about it?
Yeah, great question. We know in rural communities where there's less access to care, less access to support, and that can be all different kinds of care and all different kinds of support. It can even be faith community support. It can be support in schools for those young people. If there's not a school counselor that's available, and not every school has school counselors or a school psychologist available to them, we see greater rates of suicide. So where we have less access to care, we have less access to support, we have more isolation, we have more time alone, we see more deaths by suicide. Where there are more access to firearms, which tends to be true in the rural communities, and pesticides in rural communities, we see those higher numbers. We also see in rural areas, especially among the younger populations, let's take that, the 10 to 24 year range, social media. And social media has good and bad things to it. And for full disclosure, I work for all the technology companies, from Meta to TikTok to Google and Apple. I work with all of those companies. There's good things about social media and there's not good things about social media. And we've seen some of the impacts of that around their mental health and some risks of suicide. So it's really complicated. We also see where there's higher rates of domestic violence, which we do see in rural communities. We see that around the world. For example, in India, India has 1/4 of all the suicides in the world. Out of that 800,000, they have about 240,000 of the deaths. And they don't see it around mental illness so much as we do in this country. They see it around domestic violence and poverty. So where we see all of those things, we see greater risk. And you also have tribal nations. So where we have Native American communities, we see all of those things put those people at greater risk. And what do we do about that is really important. We need to work with social systems, social service systems. We need to work with financial counselors. We need to work with schools and businesses to make sure that we're providing those kinds of supports, even if they're online supports and access to care. We need to build in communities, whether it's faith communities or it's in sporting communities, within the workplace. We need to build communities in ways where people feel like they're more connected. But again, financial counseling, people in farming communities, rural communities have incredibly high rates of suicide among our farmers. As a matter of fact, just last month, PBS did a big documentary called Facing Suicide. It was all about suicide, really well done. And one of the big sections in there was about rural communities and the farmers, because we know those have higher rates of suicide. So connecting farmers and the feed mills, connecting farmers with the loan officers and training those loan officers and people in the feed mills and in the faith community, because there's not access to psychologists in rural communities. All of these are the kinds of things we need to do more of if we want to lower that in those rural areas.
Thank you.
Great. There was a question in the chat, Doctor, about something we discussed earlier too, about that decline during COVID, during that sort of 20 to 21 and that decline in rates. What was that attributed to?
Yes, and actually you and I talked about this just before the call started. We don't have a lot of firm data on this yet. My suspicion, based on people I've talked to around the world and my own belief on my work, is that the connections were more intentional. And that's the key, is that there was intention. We knew that people were still struggling, and we knew that they might have been at greater risk because of the isolation. So people were more intentional about reaching out and staying connected and checking in on people and making sure they were taking their medicine and that they were getting access to care. And the federal government opened up telehealth and they reimbursed for it, so therapists could provide that and provide more access. So all of these things seem to have dropped the rate during the pandemic, and as even though people in the media talked a lot about isolation, there is actually a very clear intent around the world for people to stay more connected. So we think that had a big part of it.
Thank you. Any other questions?
Looks like there's another question about medical illnesses, terminal illnesses with ALS, for example, or terminal cancer. Yes, good question. Chronic illnesses, terminal illnesses, we do see increased risk of death. There was just a case that just came out. It was in People magazine. It actually went viral over the weekend of a couple both diagnosed with cancer, and they decided to end their life by suicide. And we are seeing that. So I'm not necessarily talking here about physician-assisted suicide, which is legal in some states in this country. I'm talking about simply getting a diagnosis and it being so overwhelming that you go and take your life. We do know that any chronic terminal illness where people feel like they're going to be a burden on their family, either financially or time, or the pain that they're going to make them go through having to care for them, and the lack of independence and autonomy that they're going to have, increases their risk of death. Yes.
Okay, and then we have probably time for one more. Came in on a private message, but if someone you feel needs help, but they've cut off communication with family and friends and they're not responding, how do you follow your advice and reaching out and trying to make that contact if they're not responding on their end?
So incredibly important, and thank you to whoever asked this question. We get this question a lot because oftentimes when there's a history of mental illness, it happens for many years in families, and people feel like the family is frustrated with them and they stop talking to them, they stop giving them information, they're afraid that the family is going to be worried all the time, or they're afraid they're burdening the family, so they pull away that contact. What's really important is to just maintain that connection and say, if you need something, when you need something, whatever you need, let them know that if that time comes for them, you're still going to be there. That's what's most critical. The illness makes them push. The illness makes them create this separation. It pushes them and pulls them away from us. So we need to get beyond the illness, thought about it, and say, look, they're really struggling with this illness, and we still need to be there for them when they decide or when they feel like they need it. So just put out a message. I'm here for you if you need me, or whenever you need me, or if right now is not the time, but in 6 months or 3 months, or I'm still going to be here. We don't want them to think that we've just hit a line and crossed over it and then they can't reach out to us anymore. That only increases their risk. So leave it always open for them.
Great. Thank you so much. And in the respect of everyone's time, we'll go ahead and cut it off. But I do want to thank you, and it's not an easy subject for us to talk about or listen to, but I think we've all been touched in our lives, like you said, either friends or family or coworkers that have had to be on one end or the other. So really good advice on how to have those conversations. Those were my notes, is like, how do you do this? And you answered it. So that was nice. So thank you all for coming. And we have another one tomorrow afternoon. If you want to come back, you're welcome to sign up for that one too. And
Tomorrow morning.
yeah, or morning. I'm sorry. It's in the morning. Thank you. Because I was on the wrong time today. In the morning, always repetition is the motor of learning, as we like to say. So thank you again for your time, and have a good rest of the afternoon. And I will see you in the morning.
Thank you. Thanks, everybody.
Thank you all.